and we'll see if anyone is here. Oh, we have an attendee. Wonderful. We have a few attendees. Hi, everyone. Good morning. Just let everyone get on in here, and then we'll start with some just basic info and then head to questions. This is definitely meant to be question and answer time. Tom, do you want to go first? Want to introduce yourself to start, and then I'll go
Sure.
into.
Yeah. Greetings and welcome, everybody. My name's Tom Grothe. I wanted to join Sonia for this informal discussion with other clinicians. I am one of the counselors at Mettle, and so I thought I could make myself available, say some of what I do and types of clients that we get in the process of this work. So I'm available to answer any questions or to work with you guys in any way that seems right.
Awesome. Thank you, Tom. Hi, everyone. I'm Sonia Dolan. I'm a co-founder of Mettle Health, and I'm here to just talk about what we do and how we can partner with people working within healthcare to care for their patients and caregivers, and hopefully care for the clinicians as well in this process by taking something off of their plate so that they can do all the other things that they have to do within the healthcare system. So I'm just going to do a little bit of a level set here, and then we can totally open it up to anybody's questions. And I don't think there's anything off limits or that can't be asked. We're here to clarify and help. So any question, please feel free. So Mettle Health is born out of the idea that palliative care should be something that everyone has access to. So when we started it, the thing that we took away was the prescribing, and we don't become anyone's doctor of record in an EMR. So we get to have these much bigger conversations around all the different types of suffering that palliative care is meant to address. And we consider these, logistical suffering, emotional suffering, practical suffering, existential suffering. There's so much that goes into being a human being, living with a serious illness, with grief, facing the end of a life that isn't addressed by the traditional medical system. And we're really here to talk out those things with people. How is it affecting your relationships? How are you able to communicate with your doctor in a way that gets you the information you need? Understanding what your disease trajectory is and how to plan for it. That's a huge piece of this. A lot of the people that we're caring for are not experts in their illness. They probably become them over time. But we want to be there to help them plug in information into the gaps where they may not have an idea of what's happening and kind of prepare for what to do next. So we are fully online. Everything. Oh, got it. Patty, good question. I'll head there in just a second. So we're fully online. We meet with caregivers, with patients, with anyone within kind of the care circle. That can be family, that can be friends, someone who's caring for someone else. And there doesn't need to necessarily be a patient who comes to us for the caregiver to come to us. And that was really important for us, was to say caregivers deserve support and guidance because a lot of the time they are making a lot of the decisions for somebody else and worrying that they may be making the wrong decisions, and understanding what to expect and how to plan for the future is really, really helpful for them as well. So that was an important aspect of what we do. So we have a team, which Tom is part of. It's modeled after an interdisciplinary team, like it would be at a hospice or palliative care. We wanted to have a chaplain, a nurse, a social worker, a doctor, a lot of the different experiences, so that depending on who's coming to us and what they want to discuss, we have someone who can address those things, and hopefully also kick it over to another one of their colleagues for a conversation that might be better aided with one other person. So our clients can meet with any one person, which totally makes sense. You kind of meet with someone, you connect with them, you've told them your story, you want to keep going, or our clients can meet with multiple people. So there might be someone like Tom might be their kind of quarterback, the person who's holding a lot of it, and then maybe they go off and have a different conversation with the chaplain about something else. So we are here for any way in which our clients want to work with us. So Patty's question, defining existential. Ooh, Tom, I feel like both you and I can talk about this. So when I think of existential care, I think of people whose identity has been rocked by a change in their health. So, biggest example for me might be you get a cancer diagnosis. Who are you now? Are you going to be able to do the things that you used to be able to do? How do you define yourself? Are you your illness? And then on top of this, existential, existing, talking about the physical body of ourselves and are we existing in this world or are we not existing in this world? And the thing that many people are coming to us is a thing that is threatening their quote unquote existence in the world. So not even coming to terms, that's the wrong term, discussing what that is and what it feels like to be looking at that, I think is a special lens that a lot of us do not look at a lot of the time. And serious illness, chronic illness, end of life can focus that lens pretty deeply. So we want to be able to talk about that. This is something, it does affect you, and it's not going to be a conversation that comes up with your oncologist. So we want to be able to address that with our people who want to go there. There are people who may not want to have that discussion. Tom, I'd love to hear your thoughts on existential care.
Yeah. Hi, Patty, and it's a good question. And the way I view existential suffering is that a lot of time in chronic, progressive, and terminal illnesses, our world is shaken, and the things that we believed in
Mhm.
don't make sense anymore. And to me, that can be an existential crisis. Why do I exist?
Mm,
What is the purpose of my life? And so I have experienced that people who are struggling with really serious diagnoses sometimes do ask themselves that. And those are some very deep core issues that are important in helping someone discover how to integrate this new terrible diagnosis into their life,
mm,
how to make meaning from their life with this new part of it.
yeah.
So a lot of, existential therapists basically believe that the world has no meaning and that each person's task is to find the meaning in their life,
Mm,
not to look to the dogma of their religion or their politics, but to find what their core belief is. And a lot of times, this experience of suffering with illness will help, not help, but drive a person to look at those issues. So at least certainly in my work, I'm always thinking about that,
yeah.
is where can I help a person consider what is meaningful in their life? Where can I give someone the courage to get up each day and
Mm,
proceed and to take control of what's important in their life? So
yeah.
that's a brief
Yeah.
thing about how I would answer that,
I love
Patty.
that. Yeah,
It's
like that little bit. What is the quote? When you can find the meaning or the why, you can do. Yeah, that like meaning is a little bit of a toehold to get through the rest of this stuff.
it's something to the effect of if you have a why, you can tolerate anything.
Yes. Yeah.
And there is significance to that.
Yeah.
That that's Nietzsche, by the way.
And I think it's a special something that we address and talk about a lot that sets us apart from a lot of other providers is opening up this conversation of like, what type of suffering are we talking about? So there's a lot of ways we can address our physical suffering, but there are these other realms that also need tending to that we are very much here to have those open conversations. Um, Anyone in the attendee area, if you want to raise your hand and ask us a question, you can do that too. And the chat is definitely open if you want to just put a question in there, but I will keep kind of rolling on some other points that might be helpful for our clinical provider
Well,
colleagues.
and
Oh, go ahead.
Sonia, one comment that I
Yeah.
wanted to make, and you hit on it earlier, is we are a varied group of people providing this type of supportive counseling and care.
Yeah.
And that's fantastic because we all might come to these issues in different ways. And so you may find a match with me, or you may find a match with Natalie or Bridget or Heather. It's like there's a bunch of us out there.
Yeah.
One, and just to like, I'm a nurse practitioner. And I'm also a marriage family therapist, but a lot of my 40 plus years of work was working with terminally ill people in a primary care capacity
Mm.
as their medical provider. So I have, and many of our providers have very intimate understanding of disease progression, of what people may expect as their disease worsens.
Mhm.
And almost all of us as palliationists are always thinking, what's the next thing?
Yeah.
How do we help someone anticipate what could happen to them next in their disease progression? And then how do we help them plan it so that they can figure what's meaningful to them, and they can live their life and approach their diagnosis in a way that suits who they are. So,
Yeah.
we're all different people, but we all try and come at it, I think, from that perspective.
Yeah, yeah, I think so too. And a lot of what you just said, I think is perfect for kind of clinical partner people is we are very much here to support the patient and the caregiver, but also, to your point, Tom, of thinking about treatment options and thinking about disease trajectory, is we can have these bigger conversations with them around what they want for themselves, understanding what that treatment or surgery might be, understanding what it looks like for them after discharge from the hospital, understanding those bigger pieces so that they can make the best choices for themselves. And we feel that that's also helpful for the clinical people who are caring for them within the hospital or healthcare system. So examples of what that might look like is, we have hematology oncology nurse referral partners who might send us someone that they're caring for who they know has not had an advanced care planning discussion, and they have not talked to their family about what they want to do, and the nurse may be concerned that they're not getting the time and effort that they need to have this bigger conversation, so they send them to us to start to really discuss what it is to be living with an illness and address these bigger things like family communication, relationships, existential stuff, and then help them, like Tom said, move forward. And part of that moving forward is figuring out, what is my treatment plan? Like these things are all super connected. So wanting to take the who they are, like you said, Tom, of getting them to the best path for themselves, also we think helps the people within the healthcare system care for them better. So our goal is a lofty one of trying to care for everybody within the care circle. And I see we have a question. Laura, how is it determined which team member is the best fit for the client? Got it. So we do an intake meeting for every single person that we see, and this is a complimentary intake meeting, and it's about 20 minutes. It's for us to get to know the person and for them to get to know us and what we can do to help them. So in this discussion, we ask, kind of what's been going on to date, what are they dealing with now, what are the things that they're looking for help with, and based on that, we're very lucky that we have this small, very tight, awesome team. So we kind of have an idea of who the best person for each, in many cases, disease specific and also issue specific. So Tom, I'm just going to talk about you for a moment. Like Tom has worked with a lot of people living with dementia, and also has worked with a lot of people who are navigating couple issues. And Tom is also someone who is great at practical next steps. This is the thing you need to do, and then we'll talk again. So depending on what we hear in that intake meeting, we're going to suggest probably 2 or 3 people for that person to meet with, and sign them up with that person and go from there. But in general, we're very lucky that we have this team and we know what everyone's strengths are. So we're going to kind of put them in where we think makes the most sense. And as I mentioned before, we also have
Yeah.
different people to see people for different topics. So it might be that you have one conversation with Tom and go off and have another conversation with a chaplain, come back and have another conversation with Tom. So we do also like being able to support people in that way and have them be able to see multiple people. Laura, let me know if that helps. Yes, Patty, yes. Also, folks can look at our videos. Yes, that's another important piece. We actually recently did some little recordings with each of our counselors that we'll put out too. And the hope is that clinicians and our clients can kind of meet them in a quick way and just get a hit of who they are and what they like to talk about, so that then when clients do come to us and we mention someone, they can say, okay, I understand who that person may be. Tom, do you have any other thoughts on just like how we kind of match people up?
Sorry, my internet was unstable, so I
Oh, yeah,
repositioned
no
myself
problem.
on the
No
house. But
problem.
yeah, I think that the initial consultation usually is great at revealing what the fit is.
Yeah.
A lot of folk, we have a number of folk who are struggling with chronic disease who may not be profoundly ill. And these folk are going to do better with some of our providers who are excellent at really supporting someone and listening. Sometimes, we clinicians can get a little worn out by hearing people chronically ill. And this is a wonderful benefit for the frail person to just be able to talk about their symptoms. And Natalie is particularly good at that. Bridget and Heather are also just great.
Yeah.
So it kind of depends on what people's goals might be or what they're presenting as for who might be the best match.
Yeah. Yeah, absolutely. And your question, Laura, kind of got me thinking about something else that's really important, which is because we are not a true medical service and we are providing this kind of quote unquote palliative care. I call it a philosophy of palliative care, addressing all the different types of suffering and issues that people may be going through. We're in a position to, I believe, meet with more people than might be quote unquote admitted within a traditional healthcare setting, which I think is really awesome. So there are people that have come to us that have said, healthcare told me that there's nothing else I can do for them or that they can do for me, that I'm quote unquote, I've failed what they have offered me. Can you help? And there really is something that we can still do. We can still talk out a lot of these issues around suffering with them. So a lot of the questions that we get asked are, I have X, is this applicable to your service? And I will say about 99.999% of the time it is. There are some things that obviously are not appropriate for us to handle. But for people living with chronic and serious illness, navigating the end of a life, living with grief, that's a big one for us that we would love to see more people about, is grief. I think that there's a misconception that this type of care just stops after a death, and that's not necessarily the case. We love talking about grief. I realize that sounds a little odd, but we want to, open this up with people and talk about it as a normal part of life. So that's a big one for us too, is people who might have lost someone years ago and are still navigating their grief and just need someone to really work through it and talk about it more with. I will also say there is something different to this type of care that these guys, our palliative care team providers, are giving to people that is separate from quote unquote therapy. That's another question we get a lot, is how is this different from traditional therapy? And I think that having the lens that Tom has, that Bridget has, that Natalie has, this lens of understanding the healthcare system and the illness or disease that is causing the suffering makes a huge difference. There just is a really big difference when you're speaking with someone, and we've heard that from our clients as well, is I have a traditional therapist, they do not understand how this cancer diagnosis is affecting my life. They're not getting that, I don't know what to call it exactly. Tom, maybe you have an idea. There's a witnessing and an understanding that happens versus oh, I can see that you're upset type of thing. That I do think makes a difference for people, is having someone who can kind of straddle, I'm understanding the suffering that this is causing you, but I'm also understanding the healthcare side of things. Like, I understand how this can cause suffering and the logistics of navigating this, and then your home life. So having somebody who can see both sides of that feels really important to us.
Yeah, I'm with you on that. And I was remembering another aspect when you said that you have referring like oncology nurses.
Mm.
It occurs to me that because of I was a clinician for many, many years in a medical establishment with my 15-minute appointment to hit everything.
Right.
And what I really wanted was to get a pulse signed or an advance directive. And so I think that sometimes a metal provider can take an hour or two or three to really talk through the dynamics of those decisions that people are making.
Yeah.
Because we all know, all of you in this room know that an advance directive is just the final document. The discussion about what you want in your advance directive is meaningful.
Mm.
And that sometimes takes longer than 15, well, it always takes longer than 15 minutes. So I can imagine that that could be one place that um, a metal provider could supplement the great work that's being done to get the paperwork done.
Right.
We could prepare someone to really be able to respond to those answers. Like,
Yeah.
what about antibiotics? Well, until you think through antibiotics and the severity of your illness and when you would stop antibiotics and how you would avoid the hospital, there's a lot of details that are missing from the paperwork that when you think them through really prepares the patient and the family to confront what will be coming their way.
Yes. My gosh, we could talk about that for like hours. Every time we do a webinar on advanced care planning, I am reminded of how truly confusing the whole, well, this over here, but if say this, and even then it might not work out that way. There's lots, yeah, tons of conversation that can happen just to think about signing a pulse, signing a DNR, signing an advanced care directive. I was
I
going to say,
also know
oh
a
yeah,
number of the providers, like Ladybird, and have actually make outreach to the clinical providers,
mm,
like referring provider or a patient's actual medical providers to actually try to
yeah.
align and connect with people. So that is something that we metal providers can do or could do to help sort of smooth this process
Yeah.
with you.
Yeah. And in line with that is also, geez, I'm totally losing my train of thought here. Mortifying. Something along the lines of aiding clinicians through this process that I'm totally forgetting. So I'm going to return to that in a moment when my brain is back
Well,
on.
sorry, Sonia, I think I stepped on you a bit there, but
No.
I was reminded of a client that I had where I saw them for a year and a half, and it was a fellow with progressive supranuclear palsy.
Mm,
And I got him from diagnosis of that. And as you guys may know, that takes usually 6 to 8 months to get a diagnosis of progressive supranuclear. And I worked with his daughters, his wife, and him.
mm,
And in that year and a half, we constantly reviewed what would come next and what did he want to do. And it was a constant changing battle, or not a battle, it was a constant changing thought process.
yeah.
At first, he was like, yeah, I want to go to the hospital. Yeah, I want to get antibiotics. Sure, I'd do a tube feeding for a while, just as an example. But as we progressed over that whole period of time, this is a fellow who actually elected medically assisted aid in dying,
Mm,
had a beautiful death surrounded by his family where they were all prepared.
yeah.
But that was a very intensive involvement. And I will even say that toward the end, I needed to write a summary to the hospice doctors to help them understand what this disease progression was,
Mm,
so that they understood that he was within criteria.
yeah.
So, it's like we just sort of, with this family, it was like just a constantly evolving thing that the medical providers were terribly involved, his neurologist and primary, all along the way.
Mm.
But what I did with this family, not just with the patient, but to help them all consider, here's what's going to happen. What do you want to do?
Yeah.
Then he was empowered to make his own choices,
Yeah.
and the family was prepared.
Yeah. I mean, you're what you're speaking on now. I have three things. I remembered
Good.
one of them. One of them is exactly that. Like, we are here to help the person and their care team get to the best choice for them. Like, so it's not, if you haven't done this, you're failing at it. If you haven't elected hospice, you're failing at it. We are here to give them as much information as we can. And like Tom said, that's an ongoing discussion based on where they are. But it's really wanting the patient family to be part of the conversation and be involved so that they can make the best choice for them. Oh, Mel, I see your question. Perfect. I'm here as a marriage and family therapist, curious about resources for clients and likely at some point for myself. For the client side, do you ever collaborate with outside psychotherapists and or do you offer consultation for therapists in our development? Great question. Hi, Mel. Nice to meet you. Thanks for being with us. Okay, so the client side, we do collaborate. So a big piece of healthcare, I think in general, is finding the right thing for people, right? Is like, okay, we can do this piece, but we're not equipped to do this piece. So we're going to try to find someone else for you for this piece. And Tom, you can probably speak to this. I think that that's like outside resources, like, it could be food delivery or a physical therapist or an acupuncturist, or it could be a psychotherapist. That absolutely happens. And there are instances where we say, we can continue talking about X with you. We can't talk about Y. We need to make sure that you're getting the best care for Y. And this is why you need to go see someone else. So we are very much not trying to be the everything for everyone, but we do want to make sure that we're at least helping them find that thing that they need. I will say, after COVID, it is very difficult to find people who aren't booked 2 years out, but we will still work with this person to find the thing that they need. So in some cases, a client may come to us and we'll talk to them and it'll be clear that we are not the best person for what they're dealing with. And in that case, we will try to find them outside help and say, have you looked at this person? Have you checked out this? This might be a good place for you. So it's definitely not a like, well, we can't help you, we're out. It's very much, what is the thing that really sounds like this is what you need? Let's help you get that.
But
Oh yeah, please, Tom, go
follow up
ahead.
on that. Also, I think, Mel, hi, you're asking, will we work with a client's psychotherapist
Mm,
who they have at the time? And the short answer is yes, we'll work with
yeah,
anyone. One of the liberating things I think about mental health is we are not the prescribing providers. We are essentially could be perceived by an outside psychotherapist as a supportive community member or family member. And so, as far as I know, Sonia, we don't like, I think there are releases of information and stuff.
right,
I
right.
haven't actually
Yes,
encountered that, but we will talk to anyone because we're kind of liberated. We're not their medical provider. So
yeah,
on our side, we don't have the same constraints. So any therapist who might come to us and say, I want to talk about this person, you would arrange the
right,
appropriate release
right.
of
Yeah,
information, and then we'd talk.
yeah, yeah. Mel, same, just as you said, with the written consent, same type of forms. I authorize you to talk about my ex care with these people, same way in healthcare. And then your second question, do you offer consultation for therapists and development? Yes, we do. Actually, very recently, my co-founder, BJ Miller, and one of our other counselors, Lady Bird, have created we're calling it a curriculum. I still don't really know the best word for it. Curriculum doesn't really feel right. It's very much meant to be for anyone who is either caring for themselves, caring for another person. It's meant to address what it is to be with human beings, coping with change, coping with suffering, their own, somebody else's, how to think about communication. Where does my autonomy stop and another person's begins? So to me, it's very much a human part of what it is to care for other people or be sick and dealing with all of the types of suffering that we've talked about. And Mel, I'll reach out afterwards and I can send you a little bit more information on that. But I think that's something that we've done a tiny bit of piloting on, and it seems to be very successful with both providers and people living with illness or caring for other people. Um, and then Tom, I'm going to go back to one of the things you said that reminded me, which is the MAID physician aid in dying conversation. That's something that comes up for us as well. And we are here to talk to people about what that entails. So we're not able to become anyone's prescribing doctor for this process, but we have found that there's so much that goes into thinking about this and planning for it that is not covered in the basic information of you submit this request, you get these drugs. There are aspects of how to talk to your family about it. There are aspects of how to talk to your doctors about it. There are aspects of grief about it. There are many things that go into this that we want to have a larger conversation with people about to make sure that they really understand like all the ramifications of this. It's definitely not, I'm going to take some drugs and end my life and everything will continue on exactly as it has been. So we're also here to have that conversation with people as well. If anyone has patients or family members who are considering it, it's just making sure that they have the information they need on top of the logistic aspects of emotionally, existentially, how is this going to affect me? One story, which is my favorite, is we had someone who was going to elect this process, told her family got prepared, months of talking about it, we're going to do it. And then she decided she didn't want to anymore. And the family was very upset with her because they had planned for this. They were now in a state of mind that they were ready to say goodbye to her. And she's saying, well, I'm not going to go. So now we have a situation where how do we navigate this aspect of that? And that's definitely not something that is covered in most of the documentation that I have ever seen. So just wanting to say that we are also here to have those conversations with people. And then Tom, the one thing that I forgot that I'm remembering is we're also here to help people coach them through how to best use their healthcare providers. So thinking about tracking your symptoms. When are you feeling that way? What are you doing? What are the questions you want to ask? What is the information that you need to make a decision? So also helping people, I think, better communicate with their doctors, with their care team, so that they can get better information or feel also empowered to say, hey, I didn't really understand that. Can you say it again? So a lot of it is also just kind of coaching people through advocating, which is another piece of it. But the goal of it is to help people use the existing healthcare system that we have better. Let's see. Okay. I'm trying to think of other just fun stuff that I can fill in.
Well, one
For
thing
questions.
that I could imagine would be really fun for me
Mm,
is having, as I mentioned, I'm a marriage family therapist, but haven't practiced for such a long time. The bulk of my expertise is end of life care,
mm,
like boots on the ground. Here's how you control symptoms.
yeah.
Here's what's going to happen next. I would like to work with therapists who are doing the in-depth supportive psychotherapy work with people, but maybe prepare the therapist for here's what to expect
Mm,
to happen.
yes.
Here's where you may need to be focusing, or here's your time window
Yeah.
for their ability to work with you.
Yeah.
And here's how you tell that difference. So I think that there could be a real opportunity for experienced mental providers who have all that physical experience to be able to share that with
Mm,
psychotherapists who may not, who have no
yeah.
training.
Yeah. Yeah. I mean, now we're just figuring this out with everybody. Thanks for watching, y'all. Is Bridget has brought that up too, which I love. The idea of new clinicians, or maybe just, they've had a certain amount of time, but just want a little bit more and a little bit more feedback and thoughts on these aspects of things, which I think is wonderful. And I love that idea so much, especially from this team of y'all who have over 100 years of experience combined. Like there's a lot of wisdom to be given. I think I love that idea. Yeah, very much.
The other point I want to make to clinicians watching us is that Patty had mentioned the YouTube channels. And the Metal has an extensive library of talks, and I think that it can reveal that are free, and I
Mhm.
think that that can reveal to all of you the things that we are thinking about when we're
Yeah.
working with folk.
Yeah.
I have talks that I give with BJ, and we've talked about courage and hope,
Yep.
multiple losses, awe and synchronicity at the time of death. Those
Mm.
are just some of the ones that I've given, but each of the providers have shared some of what their expertise is. And I think that you'd see in watching those that it isn't simply here's how to do an advanced directive.
Yeah.
It's what's the significance of the advanced directive, or here's some of the meanings and significance that are going on as a person is chronically or progressively ill.
Yeah.
Just you might want to just check those out if you're looking.
Totally.
And
Tom, you're always so good about plugging the videos. Thank you so much. We do. We have an extensive library of videos that anybody can watch. And that's kind of the goal, is that anyone will watch it and send it to anybody else. And just like Tom said, they address all the things that we think are important, and that we're constantly adding to that too. So we kind of do repeat ones of caregiver issues, and every year we do one on pet loss. But like Tom's point on hope, that's a huge concept in everything that we talk about, but I don't see a whole lot of providers talking about hope on their, things that are offered to patients. It's very much like, I'm filling out an advanced directive, caregiver coping. So we really do want to get kind of underneath these things and not just say, here's an advanced directive, pick your proxy, but okay, who is your proxy, and how can having this, whoever you assign, like, what are the things you might have to worry about that? And why should you have a conversation with the rest of the people as to why you picked this person? Like, there's so much that goes into just writing someone's name on that form. So a big piece of this is also just getting people to think about hope, multiple losses, living in unknowns. Like, these are all aspects on top of how to navigate the ER. There's very practical stuff that people really need to know, but then Tom is so great at these. I highly suggest you check out all of Tom's bigger conversations on human things that go into living with change and illness and scary diagnoses that are just part of what it is to be a person navigating this. So thinking about those things that don't have a solution per se, that they're kind of an open-ended way of thinking about these parts of serious illness. Laura, what can clients expect as far as fees? Are there any future plans to offer insurance coverage? Great question, Laura. Thank you. So fees, we have a couple different ways that clients can work with us. People can elect to do a single session at any time they'd like. That is $220. I want to make sure to say we also offer sliding scale to people. They just need to let us know that that is something that they would like to do. And we will work with them to figure out what makes sense for them. The other things that we have this little, call it a bundle of 3 appointments that can be made over any time in 6 months, and that reduces the price by 25%. So it's, I think, like $154 a session for an hour-long session, which I think is a deal. And then we also have 90-day memberships where people can elect to have either 9, 15, or 20 appointments within those 90 days, and they can use them how they want. So that might be, we'll have a family come to us who just got a stage 3 pancreatic cancer diagnosis. They want to kind of front load some things. They want to have 2 or 3 conversations in that first week, really think about stuff. Maybe they'll go away and then come back at a different pace. So there's different ways that people can work with us. I will say health savings accounts, we have submitted super bills to people for those, and they have submitted them for reimbursement. So that is something that is accessible to clients, patients, caregivers. So we're happy to provide those when asked. Insurance, man, I hope so, Laura. I hope so. I think that we are very much in a place to reduce cost for a lot of things, ER visits, treatments. So my hope is that yes, someday that's something that we can say we offer. But in the meantime, we do try to make it work in any way we can for people, because we recognize that everyone is has the potential to live with an illness or someone caring for someone who is. So we want to be sure that we're here in some capacity. And to Tom's point, those videos are very much covering a lot of what we talk about in these discussions, so that can be helpful. And just also to remind everyone that that first 20-minute appointment is totally complimentary, and we can talk about the sliding scale stuff there as well. So if it's really just getting an idea of how we might be helpful to someone, there's no reason to not do it. Okay, let's see. Oh yeah, thank you, Laura. Thanks for being here. Let's see. I think of other fun stuff about our service that I get asked all the time in these.
Well, I'll make a point that you had touched on earlier, Sonia. Occasionally, someone will come to us and we're like, I don't know if this is the fit. And the places that I have discovered that is someone may show up initially with a presentation of, I want to process the grief of my dad dying. And in the series of an hour or two, a couple sessions, it really becomes clear that what someone is struggling with is uncertainty about their marriage. And like I'll meet with the person and their spouse, and we'll be talking, and it's clear that's not going on so well. And so while I have the capacity as a MFT to manage that, that isn't probably the best place. And I want to get them to a therapist
Right.
in their community so that they can have sort of direct supportive counseling.
Yeah.
So we might go into dad's death, but things reveal themselves.
I think that's such a good point. I mean, really what we end up talking about is like life. And I'm thinking, Tom, of the time you spoke with someone and what you ended up getting them was a divorce lawyer, if I remember correctly. Like this illness has a way of bringing these other issues that may be going on, shining a light on them in a new way. So for us, even if that's what we're helping you realize, like that's okay. We may refer you back out to someone who really can help, but that is part of this process, is like, where is the pain point here? And where's the thing that we kind of need to get through to get you to a place where you are feeling better? So I think for me, I don't know how you feel, Tom, but I love it when that kind of stuff happens. Like we come into this type of conversation and then it morphs into something else. And there's something really lovely about that, because all of a sudden we're talking about, a marriage and kids and all these beautiful life things versus I'm thinking about this treatment. Should I do it or not? So it's, yeah.
And the other component of that, just for referring clinicians, if you have someone who's a little odd or you can't quite get them across the finish line you're not sure they're understanding their diagnosis, or they're just not presenting, it could be that there are deeper issues in their family or in their character structure or whatever. But sometimes a few meetings with a mental provider might peel away some of that and enable you to proceed. So it's great to get people who really want to do in-depth work and drill down the meanings of their diagnosis and their life. And that is what Mettle does really well. But Mettle also has the capacity to bring those questions to people who are struggling and would never even think about what's meaningful in their diagnosis. So, and that's fun. And you can get people who didn't really think about that before and then are realizing like, oh yeah, this can be meaningful in my life. And I can grow from this. Even though I've got a terminal illness, I can grow personally.
Yeah.
So, that's hot when that happens.
Yeah, I agree. I'm gonna switch to something totally not related, obviously, to Mettle, but there's such a beautiful thought. I wish I had a better follow-up to it. But what I was going to say was we're really here for like any moment along this trajectory. And I think what happens a lot too with us is people think, oh, you're for death. This is for death. This is for people who are dying. And that we are very much there for that. But it's all along the trajectory. So we're trying to use a BJ phrase, make good on the promise of palliative care, which is from the moment you receive this diagnosis, all the whatever trajectory that takes to the end of a life to grief, we're there to have those conversations. And I think there's this feeling that it's just this one section or it's just cancer or whatever that might be. And it's really not the case. So it could be someone who just received a diagnosis, who just needs a space to talk out like, okay, my world has been rocked. How do I move forward? What do I even have time to think? I think that happens a lot with people that we get. They're like, I have to make a treatment decision tomorrow. And then we can have a conversation and be like, okay, I think you actually have more time to think about this and really marinate in it and think about what you want to do and how you want to do it, and just give them a different receptacle to kind of think about their situation in. And that can go to remission. We're here for that. We're here for periods of time when, you know, you're not dealing with an illness, but you've been dealing with the illness so often that now you don't know how to connect anymore. We're here for when a diagnosis changes or a chronic illness gets worse. So there's many moments along an illness trajectory, and we're talking about multiple illnesses, diseases, long COVID. That's one that we've got with people right now, is navigating long COVID, which is full of so many unknowns because the illness itself is a super unknown. So walking people through what it is to not be able to feel good when you're feeling good because you know that feeling bad is coming. So how do you navigate those spaces? So these are the types of conversations that we get to have with people, but it's really, there's no time limit on this. It's anywhere along the trajectory, and that feels really, really important to us. And that goes into grief as well.
One thing we may not have talked on a lot is Mettle can be a support to caregivers, whether that's family or professional caregivers.
Yeah.
And maybe some of you would just like to talk about cases that you've had
Yeah.
and say how it's impacted you.
Yeah. That's a
Right.
really, thank you. Yeah.
Yeah, to
Perfect.
deepen it. We would like to deepen the experience of this struggle for everyone.
Yeah.
And
Yeah.
so caregivers,
That's such a beautiful way to say it. Yeah, Tom, you're totally right. Like the people who are here, we assume you're caregivers too. It may not be you're a family caregiver, but if you're caring for someone within a healthcare system, we also consider you a caregiver and want this to be a space, you know, like Tom was saying, as kind of a professional mentorship, but also we find that clinicians caring for people are going through a lot of similar issues of moral injury and not being able to do the things that they want to do or say or feel that what is being provided isn't the right thing. And where do you go to have those conversations and talk out how to, you know, maybe add in your humanity a little bit or understand the situation differently. So we're very much here for professional clinical caregivers as well. Patty, you said last fall, BJ said that your sessions are a safe place to fall apart. That might be a way for people who feel intimidated. Yeah. Yeah, that's one of the things we say is just it's a space to feel anything. And I think because we're not associated with a healthcare system, so we're not going to be writing a note in your chart about anything that was said. You kind of exist in just the space with the counselor who's speaking to you. So any emotion is welcome. You're pissed, you're angry, you're happy, you're sad, you're jubilant. All of those things are totally welcome. And a lot of the time, people just don't have a space, like Patty said, to fall apart. There's not a safe place to do that because we feel like we may need to be holding on to some type of personality type for the other people around us, for the patient, for the caregiver, for our other family members. So we want to be a space where anything is welcome. And our counselors are here a lot of the time. Tom, I don't know if you want to speak on this, to just witness it and just recognize it and acknowledge it and say, you're right, this is really hard. Or you're doing the right things. I know it doesn't feel like you're getting the, but you are doing the things that you're supposed to do. And I think that's a big piece of what people get, is just having someone like yourself listen to them.
yeah, absolutely. Just witnessing is terribly important, both for the person struggling with a progressive or terminal illness, as well as the caregivers. A
Yeah.
lot of times caregivers, both professional caregivers and family members, just are not the focus. And so to have some time to talk about how they're doing with the process. And I always try to remember that, no one became a doctor or a nurse or a social worker, to fill out paperwork or to be a manager or, to chart,
Right.
So to remind caregivers the the depth of this and to touch that feeling and to acknowledge it all together. I think that goes a long way to helping with being burnt out and to remembering why you're doing this work,
Yes.
So I try to keep that in mind when I'm working with folk.
Yeah, yeah, absolutely. I mean, I think it's a huge piece of it is, we talk about healthcare a lot, obviously, with people who've had bad experiences. And what we tend to always say is like, just like you said, Tom, the people who are working within this space did it to care for other people and recognizing the burden that they also have on top of caring for other people to hopefully help create a space of understanding for them as well. But yeah, it's a really big piece of it. But I will say for a lot of our clients, and I've heard this directly from them, having someone listen without trying to fix it there's something to that. And just having someone listen without saying, this is the prescription you need to take to stop that. This is how you cure this. But listening with the understanding that we may not find a quote unquote solution in that moment. That's also what we're here for, is just to talk these things out, because there may not be a solution. A lot of this stuff is just hard, inherently hard. And we also want to make space for that. So we don't want to create an atmosphere that's Pollyanna-ish and says, okay, great, come here and we'll fix it all. It'll be great. And we'll send you on your way. It's to recognize that this may be really hard and you just need someone to talk about how hard it is. And we're here for that.
I was kind of curious who's here. What sort of providers
Yeah.
are we talking to, and what are your interests in metal? I don't know if people can just
If
type it in.
anyone
Time.
feels so
I'd love, if
moved,
you
if
want
you
to
want to
share,
put it
I'd
in the
love to hear.
chat,
Yeah.
yeah, yeah, absolutely. If anyone wants to add it to the chat so we can learn a little bit more about you. I should have started that way. Well,
It might give me a sense of what all else you might want to hear about what metal does. But I feel like Sonia and I feel like I think you've done a good job
oh,
explaining.
thank you.
So
Perfect. Wonderful.
that's who
Wonderful.
we are.
Yeah. No, I mean, I think that's I think so too. We definitely covered some stuff and there's some, minor details that we can always clarify. But I think the main one that I would just love everyone to walk away with is we're pretty much here for every situation that would qualify for palliative care out there in the world, but even more so. So chronic, serious, end of life, grief, like we're here for all of that stuff. You don't need a referral because we're not a medical service. So anyone can come to us directly and say, I would like some help. Can you talk to me about how you can help me? And we can do that. So there's no restriction on any of this. We're very much specialized in grief. Yeah. Okay. That's what Laura is. Oh, nice. Thanks for being here, Laura. But those are the big ones, is that worst case, someone will have spent 20 minutes learning about what we do. And that's, I think, time well spent. And they can always come back. Always. We can have a conversation 6 months ago and have someone come today. Great. Like we're here for those moments. We're here for any way that people want to work with us. It's very much based on like what they're needing and what the best interaction mode is for them. I mean, we're 12:55. We've talked about Metal for a while. 12-ish years, hospice palliative nurse, LVN, RN triage emergency. Wow.
That's great.
Let's see. Patty, is there a short YouTube video that summarizes what you do? I think we have a really short one that BJ did a long time ago, but you know what, Patty? It's probably time to dust that off. So your question is making me think that we should probably do a new one, which I'm into. Let's see. All right,
Thanks for
great.
sharing sort of who you guys are, and
Yeah.
great to see clinicians out there working so hard to make a difference and then wanting to do more,
Yeah.
recognizing that the medical establishment doesn't always meet everyone's needs, and you're looking for creative answers to supplement the work you're doing, and
Yeah.
we just might be able to help.
Yeah, awesome. Tom said it best. Thank you so much, everyone. Thank you, Tom,
Yeah,
for being my partner in crime on
thank
this.
you,
Really
Sonia.
appreciate it. Have a wonderful rest of your day, everyone. See
All
you
right.
soon. Bye.
Bye, buddy.